Let us start with the case scenario. This is a 9-year-old girl. And we know in pediatrics that age and sex matter when children present with illnesses. And she was a girl who presented with history of fever of 12 days duration. The fever was moderate to high with chills and rigors. It was a continuous fever with the temperature being relieved temporarily with antipyretics. Fever spikes would occur every 4 to 6 hours. There was no diurnal variation, and the fever would not touch baseline despite antipyretics. So, what do I understand by this very first slide? In a 9-year-old girl, if this girl has fever of 12 days duration, the usual fevers in children, most of which are viral, which are much more common in preschool children, is not an entity to be considered here. Number two, a fever of 12 days rules out common infections which would settle down by this time. Further, this girl has a fever which is not accompanied by any other system involvement as of now in the form of cough, cold, sore throat, red eye, watery eyes, vomiting, loose stools, or a skin rash. However, the possibility of Epstein-Barr infection can be considered because that is one fever that can go on and on and on. In a continuous fever with regular spikes without diurnal variation, not touching baseline despite antipyretics, would generally make the common viral infections less likely. Now, as Dr. Palini Raman very clearly said, response to paracetamol does not differentiate an illness between bacterial and viral. So we have a child who is showing fever as a sign of inflammation. Whether this inflammation is infection triggered or triggered by anything else is what we have to look for. 4 days, and before I go into the next slide, a 9-year-old girl, what are the common infections that we would look for? The common bacterial infections in a 9-year-old girl could be pneumococcal, streptococcal, salmonella, tuberculosis, mycoplasma, and rickettsia. So these are the common bacterial infections that we would look for. Now, based on only the history, a good number of these can be ruled out. As we discussed, Epstein-Barr virus is to be kept in mind. And since this is the age of 9 years, inflammatory disorders, particularly in a girl child, autoimmune conditions, and malignancy, in that order, we need to keep in mind. 4 days after the febrile illness, she was noticed to have bilateral cervical lymphadenitis by the referring doctor. The child received oral amoxicillin for 7 days with no clinical response. Baseline investigations done by the referring doctor, including urine routine and microscopy, were normal. I need a little more details here. Number one, this cervical lymphadenitis, was it tender or non-tender? If it is a tender lymphadenitis, then my thought process would be a acute inflammatory, mostly infective lymphadenitis. Number two, I need to know the dose and the compliance when amoxicillin was given. Amoxicillin in a good dose of 50 milligram per kg given for 7 days would be a good antibiotic for acute suppurative lymphadenitis. So presuming that this child has taken the oral amoxicillin in the right dose, right frequency with normal compliance with no response, this child is unlikely to have the common bacterial lymphadenitis that we would generally encounter. And for a bacterial cervical lymphadenitis, there should be a focus somewhere in the throat or in the skin or in the scalp, and that is not forthcoming. She has no significant past illness. Growth and development were age appropriate. She was fully immunized, including typhoid vaccine. What do I understand by that? A child whom we consider the possibility of a autoimmune condition or a immune deficiency condition is unlikely not to have any symptoms by the age of 9 years, whether it is T cell mediated or B cell mediated. A de novo primary immunodeficiency disease at 9 years is a little unusual at this age. And whenever children have any of these disorders, the growth and development will generally not be age appropriate. Despite the child being immunized with typhoid vaccine, still paratyphoid infection is possible. That is one consideration that we need to keep in mind. Now, at this point in time, I would like to ask myself three important questions. Am I dealing with a normal host or an abnormal host? Looking at this child's growth and development, looking at this child's past history, I would consider this girl as a normal host. She has no antecedents to consider her abnormal all of a sudden. The second question I would like to consider is whether this child is at high risk for serious bacterial infection or not. This child is less likely to be a child considering for serious bacterial infection. One, because of her age, serious bacterial infections are much more common in infancy, not at 9 years. And number two, 12 days of fever and she is stable. So the chances of a serious bacterial infection, I would put it a little lower on my cards. The third question I would ask myself is whether this girl is stable or unstable, meaning whether her vital parameters are normal or abnormal. So the fact that she has tolerated fever for 12 days without significant problems means that this girl is a stable child. So that's the understanding. The family history was not contributory. There was a history of contact with tuberculosis. Her second cousin, age 16 years, was suspected to have systemic onset JIA 2 years ago and is now okay. Now, none of these seem to me very specific to me, and this red herring of her second cousin having JIA may not matter much to us. However, JIA is still a consideration in this child because many times up to 4 weeks, these children present only with fever and the other manifestations of JIA can occur later on, but that may not have a bearing to her cousin having JIA. What is more important to me is her travel history. She has gone to her native village and stayed there for 2 weeks. What she did there, did she go hiking? Was she in contact with animals? Was she in contact with pets? Did she eat any unusual food like squirrel meat or etc. etc.? These are possibilities that we need to consider in considering the possibility of a zoonosis that would cause fever in this 9-year-old child. Now, what could be our deductions at this point in time? Tuberculosis is the commonest. Can tuberculosis present with high fever? Rarely, yes. That is a consideration in any child in our country. And tuberculosis can manifest with any sort of presentation. A fever of 2 weeks is something that we need to consider. The next consideration, as we discussed earlier, would be Epstein-Barr viral infections. The third possibility I would consider, particularly because she has traveled, is the possibility of leptospirosis. It would be good for us to understand that even if pet dogs have been given leptospira vaccine, it does not prevent the pet animals to harbor leptospira in their body, though they may not suffer from it. Is typhoid possible? Typhoid is a common illness that we would keep in mind. However, in typhoid, the possibility of cervical lymph nodes is very, very unusual, though the lymph tissue in the intestine are affected. Can she have rickettsial fever? Possible, because she has fever, she has got a cervical lymph node enlargement. But the only point that is not favoring rickettsial fever in the history is that the incubation period of rickettsial fever from the time of contact is between 1 to 2 weeks. And this duration does not fit in this particular child. I would also like to consider the possibility of infective endocarditis, because these days we know that infective endocarditis can occur even in a child with normal heart anatomy. So that's a possibility that I would like to consider. Which zoonosis comes into my mind, and that is acquired toxoplasmosis. They can have fever, they can have lymphadenopathy, they can have organomegaly, etc., etc. Would I consider non-infective illness? Yes. The first non-infective illness top in the list would be juvenile idiopathic arthritis, because this is a girl child, she has got fever of 2 weeks. That is a possibility. Autoimmune disorders like SLE or the other vasculitis are also a consideration. Lymphoreticular malignancies are very low in the list. Is she likely to have a fungal disease? She has traveled, so all these fungal diseases are still a possibility. Ravi Shankar discussed something post-COVID. Am I dealing with an atypical Kawasaki? The clinical features do not give us much clues to consider the possibility of Kawasaki. Last but not least in the list, am I considering the possibility of drug fever? Drug fevers are known to occur in children who are on medications. The classical presentation of drug fever would be that the fever spikes occur at the time of administration of the drug, and within 3 days of stopping the drug, the fever touches normal. So that would be my take as far as the history is concerned. Thank you.
Okay. This is like the first 6 overs of a T20 match power play. You have wild hits, you may get sixers, you may get no runs, sometimes you may get out also. So Naghabhushana had wild swings at infections, at inflammations and autoimmune, and also at drug fevers. So with his line of argument, he has ruled in and he has ruled out certain conditions. Just for a clarification, he had asked for one doubt whether the lymph nodes are tender or not. The doctor clearly said they are not tender lymph nodes, right? And the antibiotic course was given, was appropriate for duration. Now, with that thought process, I'd like to see if any of our panelists have any other different line of thinking, or would you agree with Naghabhushana's line of thinking? So before we go further into the discussion, you can raise your hand and please answer so that we save time. Anybody?
Yes, sir. Me.
Yes, Jagdish, sir.
I think it's a very interesting case and well discussed by Dr. Naghabhushana. I have some more thoughts which I would bring in here. Right now, we have a child who has had fever for about 12 days, a 9-year-old child, and has had basically just the only physical sign that you have told me right now is that this child has bilateral cervical adenitis. But we don't know whether this child had any inguinal adenitis, any axillary adenitis, any splenomegaly. That has not been mentioned. So this seems to be, is this a generalized disease or this is a localized disease? We do not know that. So while I agree with Dr. Naghabhushana that we should definitely consider EBV as one of the possibilities and toxoplasma, which will produce an EBV-like picture, we also need to consider other disorders like CMV, which also can come with cervical adenitis, IM-like picture. And also we need to look at whether there is a possibility of HIV, because HIV also can come to you with prolonged fever at this stage. It's not as if that this should be a chronic disease, it could be an acute HIV. So that is one thing we need to keep in mind. The absence of tenderness, probably at this stage may rule out Kikuchi, but that's one thing which I would keep in mind. The other things, as far as travel is concerned, brucellosis, especially if she's traveled to a village, needs to be kept in mind, because that again is an RES disease with prolonged fever. Now, as far as the one observation is that this child was given amoxicillin and did not develop a rash. So infectious mononucleosis may be slightly lower on the cards on that kind of a finding. Now, the typhoid vaccine was given, but we don't know which vaccine was given and when it was given. So if this vaccine has been given at 1 year of age, then this probably is of not much significance. So typhoid also needs to be considered. We have also looked at other possibilities, but see, these are some of my thoughts. I would still say that the door is wide open. We have basically 5 groups of conditions we need to look at: an infective disease, either bacterial or viral, a rheumatological disease, an immune-mediated disease, a malignancy, and disorders of unknown etiology, like even, for example, Langerhans cell histiocytosis could come with prolonged fever. So any of these are still possible. We don't have anything specific to tell us which one it is.
Yeah. So basically, you are agreeing with Naghabhushan's line of discussion. In the chat box, we have got an additional differential of Kikuchi's disease, which Jagdish has just touched upon. For want of time, we have no other raised hands. So I'll ask Naghabhushan to proceed.
The only point that I would like to also add is that if you are considering the possibility of Epstein-Barr virus infection, skin rash is much more common to ampicillin and not to amoxicillin. Ampicillin-induced skin rash is something that is known. Now, on examination, she was toxic and febrile. Recorded temperatures ranged between 101 to 103. She had chills and rigors with raised temperature, bilateral cervical lymphadenitis, non-tender, non-matted, measuring 1 to 2 centimeters. There were no signs of inflammation and no sinuses or fistula. She had a single left axillary lymph node measuring 2 centimeters, non-tender. BCG scar was visible on the deltoid aspect. What do I understand by this slide? This girl has got subacute lymphadenopathy because the lymphadenopathy is almost occurring at around 2 weeks of time. The non-tender lymph nodes also gives us clue that they are in 2 anatomical sites, particularly the axillary lymph node. Now, are they significant? Any lymph node in the cervical or in the axillary area, which is more than 1 centimeter, is clinically significant. And in the absence of tenderness, acute suppurative inflammation of the lymph nodes are a little less likely. I would consider the axillary lymph node much more significant than the cervical lymph node, because the axillary lymph nodes do not generally enlarge except in situations where you have a BCG vaccine. If the axillary lymph node is involved in any particular situation, it is very important. So where do we stand now? We have a child who has got systemic onset illness with fever and toxicity, and the fever is quite significant, with involvement of the axillary and the cervical lymph node. Now, I was interested to ask Professor Subbrao whether there was a reaction around the BCG scar. Because if you have a typical
BCG scar was normal, no reaction,
so
no flare.
That is not there, then I would keep the Kawasaki disease a little below in my list. Now, I would want to do a clinical examination in this child, completely undressing the child to try and see if we could get an HR. Where would I look at? I would look at the axilla because I have a lymph node there. I would look at the nape of the neck and the hairs around. I would look at the perineal and the perianal areas as well as the inguinal areas. She had mild pallor and no icterus on admission. Her weight was 25 kg, expected is 27. She is 25th centile and her height was 133 and expected was 131. which means this girl is a well preserved child before the onset of this febrile illness. Pallor could indicate many things in a febrile child, and with the significant lymph node involvement and pallor, we also need to consider the possibility of whether the bone marrow is involved. Now you have this child who has a 4 centimeter spleen, which is soft to firm, non-tender. Her liver was palpable 4 centimeters below the costal margin and non-tender. The other systems were normal. In view of the cousin having diagnosed Sogia, a detailed musculoskeletal examination was done, which was normal. For any signs of joint inflammation, there were no signs of admission. Now, in addition to fever, which started first, in addition to bilateral cervical lymphadenopathy and axillary left axillary lymphadenopathy, we have an addition of the hepatosplenomegaly, which means this child has got a significant febrile illness with involvement of her lymphoreticular system. And therefore, we need to focus on diseases which could cause the involvement of the lymph nodes as well as the hepatosplenomegaly. One thing that bugs me is the soft to firm spleen. Generally, in an acute infection, the spleen is soft to palpate. A firm spleen will always tell us that the spleen has been there for quite some time. And most of the acute infections, particularly hepatitis, the acute inflammation generally causes little bit of pain and tenderness, and here both of them are missing. Whether she had an evanescent skin rash with high fever is something I would want Professor Subbarao to answer. Now,
No
there
rash.
are
No evanescent rash.
So now there are a few no's here. We considered enteric fever, but enteric fever does not cause cervical and axillary lymphadenopathy, nor does it cause a soft to firm spleen. In fact, the spleen in enteric fever is soft and small. Many times we struggle to feel the spleen, and a 4 centimeter spleen in a child with enteric fever is very, very unlikely. And a girl with enteric fever has the timetable that in the first week it is non-specific symptoms. In the second week, which this girl has, is a week of respiratory symptoms. And this girl does not have any respiratory symptoms. And the third week is the week of GI manifestations. At this point in time, I would like to remember that great dictum that uncommon manifestations of common diseases are much more common than the common manifestations of uncommon diseases. While in working diagnosis of enteric fever, we have discussed this. Mantoux test was done at 72 hours and the induration was 8 millimeter. I have two comments on this. Number one, in a 9-year-old child, even without tuberculosis, we are likely to get a positive Mantoux because that is the age at which Mantoux positivity increases. And this girl has got just a 8 millimeters Mantoux. So that makes tuberculosis less likely, but she has been subjected for lymph node biopsy. So I didn't think that the lymph node biopsy would yield tuberculosis because of the acute response as well as the age of this child. And in cervical lymphadenopathy, Mantoux positivity is likely to be much more than in other forms of tubercular disease. Our understandings and possibilities so far. I think I will go to this and come back. While on antibiotics, she was found to have mild icterus and the liver, which was palpable at admission, increased in size and became tender. And then the abdominal ultrasound, which said hepatosplenomegaly with a few mesenteric lymph nodes, etc., and normal ecotexture. So what is our understanding about this? Now you have lymph nodes in the cervical area, you have lymph nodes in the axillary area, you have lymph nodes in the mesenteric area also. plus you have hepatosplenomegaly. What are our possibilities we would consider? And the liver, which was non-tender, has become tender now with increasing size. That means this liver is acutely inflamed. Is this liver acutely inflamed due to an infection, or is it part of an inflammatory process? The common things that we would consider: hepatotrophic viruses. Common among them would be hepatitis A and other viruses. Hepatitis A can cause fever, non-specific symptoms, and may or may not develop jaundice. That is what most children have, but this girl has got uh, fever, lymphadenopathy, hepatosplenomegaly, and tenderness. So that is one possible consideration of a viral etiology which has tendency to involve the liver. Does she have Weil's disease? Now, leptospirosis can present in anictric and icteric forms. Now, this is the icteric form of leptospirosis. Now, the point which is against leptospirosis is the absence of severe muscle and joint pains. These children have intolerable muscle and joint pains before they develop icterus, and that is what is missing. Now, are we considering the possibility of brucellosis? Because this girl has traveled to her hometown, she would have consumed milk which was not pasteurized. The ultrasound does not show microabscesses. Does that make brucellosis unlikely? The answer is no. Less than 50% of children whom we suspect brucellosis only have microabscesses in the liver, and the others may present with no microabscess in the liver, but the other features with which brucellosis manifests are not forthcoming. Lymphadenopathy is a possibility. Now, I would continue for
one second, Naghabhushan. Just for a few seconds, ask the opinion of the panel. At the moment, you have brought in hepatotropic virus, and secondly, you have said tuberculosis is unlikely in this situation, and you have brought in a possibility of brucellosis. My question is, what is the explanation for a liver which has 4 centimeters to suddenly, under supervision, become large, and then child is having icterus? That's the question you have to answer. But before that, let me see if any panelists have got a different viewpoint, and Naghabhushan can answer this acute onset liver insult. Anybody?
Yeah. I think Dr. Naghabhushan has very nicely analyzed the case. Now let's go back to, I think, looking at to why this liver has suddenly enlarged in size. How can the liver enlarge? Basically due to either there is a congestion in the liver, either there is an infection in the liver, either there is an infiltration in the liver, or there is an immunological reaction in the liver. So something like that is happening here. So what is happening here? Is this a congestive hepatomegaly? Or is this a infective hepatomegaly? Or is this related to an infiltrative hepatomegaly? Or the other possibility is this drug induced. You have been giving ceftriaxone. So what was the liver function prior to starting, and the alkaline phosphatase prior to starting ceftriaxone? So is this child going into hepatocellular involvement because of a drug? So I think we need to look at it from various viewpoints rather than just one. And if you ask me, my overall look at this child is this child has a RES disease, some reticular endothelial disease, because you have all organs of the RES primarily affected. You have the lymph node in multiple sites, you have the liver and the spleen. All these are affected without much involvement in any of the other organ systems. You don't have any other organs which are primarily there. Now, basically, how can this happen? This can happen due to 4 conditions. One is this could be an infection which is producing it, which is primarily an RES infection. What are the primary RES infections? Basically 3 of them, which we need to look at chronic infections. One is this likely to be tuberculosis? Is this likely to be brucellosis? Is this likely to be something like a rickettsial infection, which can affect the RES? So these are the 3 main bacterial disorders. The other thing, of course, viral, we have already discussed, EBV and the EBV group and HIV. So I think what we need to do is to look at what is the cause of this RES involvement. The second group is the immunologically related issue. The third group is the storage disorders. Is this something which is causing a problem? And finally, is this a malignancy, which we have missed completely? So I think what we need to look at is we have to go back into our history, look at all this. The other thing which can do it, which Dr. Naghabhushan mentioned, is this likely to be an SBE, which is producing a high immune load, and therefore the RES is getting stimulated. So there is a combination of both infection, immunological reaction, and probably some degree of congestion, which is causing the jaundice. So I think we need to look at all possibilities, because right now we don't have any clear idea.
Yeah. Thanks, Jagdish. And Naghabhushan, your take on this sudden liver enlargement with tenderness.
I would consider the increase in liver size as a part of the primary inflammatory process itself, which means that the ceftriaxone that you had started made no difference to the child. And therefore, that same inflammatory process that had started the hepatosplenomegaly increased further. To me, the same inflammation is increasing and getting further. Now, the other possibility that I would consider is that of a vasculitis. Now, in vasculitis, the only point that is unlikely is that the lymphadenopathy. Vasculitis generally does not cause lymphadenopathy, and therefore that is the point that I won't consider only on this basis. Now, is
This
it
child, one second. This child has been in the hospital for some time.
Yes.
Could the liver instead be a super added problem on top of an underlying already liver disease?
Now, this child has got a hepatomegaly of 4 centimeter, and that had happened before the child came into the hospital. And this child continues to have fever. This child has no other symptoms, and therefore to consider another infection on top of this infection, to me appears a little less likely. As they say in medicine, put your apples in one basket. And before I conclude, this child is unlikely to have a metabolic disease or an infiltrative disease. Age-wise, 9-year-old to get any infiltration, like Gaucher's, etc., is a little unusual. And there, the involvement of the organs would be much more than what this child would have got. And number two, there it is an interstitial inflammation, and jaundice or the pain is a little unusual. So I would consider acute ongoing infection, an inflammatory process, much more in the list. Number three, Dr. Jagdish mentioned about malignancy. Now, malignancy is one disease which can present with many symptoms. Now, what symptoms of malignancy are okay in this child? Number one, this child was well preserved before she started fever. That could happen. Fever is okay. Lymphadenopathy is okay. Hepatosplenomegaly is okay. But she has very mild pallor. Pallor is something that usually accompanies a lymphoreticular malignancy, and that is not very forthcoming. So I would rather keep malignancy low in the list.
Just to put things in proper perspective, the liver was palpable 4 centimeters at the time of admission, but the new symptom of it enlarged more than 4 centimeters while in the hospital. The liver, which was not tender, became tender in the hospital. So that is what you have to look at. Before that, I'd like to say, I want Naghabhushan's response on Palani Raman has said, is there a possibility of HLH in this patient?
The possibility of HLS is less likely in this child, particularly because HLH is an acute rapid presentation. And this child is not going in a rapid way. This child is going in a much slower way as compared to the presentation of HLH. And I wouldn't consider HLS as the possibility in this child.
If I can come in here, I think we need to look at it in a different way. And that is, see, this child has been running fever. Maybe the initial fever was dengue. We don't know. We only are seeing that child after so many days. So this could be a post-dengue HLH complication. So I don't think we should go by saying that HLH is not possible. I think the important thing that we need to note is right now, we have certain probability of disorders and less probability of disorders. But everything needs to be kept in the basket because we still don't know what's going on. We still need a lot of information.
Yeah, I think HLH as a possibility is necessary because the line of treatment and aggression with which we do affects the mortality and morbidity. So I would not totally discard. I would probably investigate for it, and if it's negative, probably rule out. Okay, Naghabhushan, over to you.
Lymph node biopsy reported as reactive adenitis and was negative for gene expert for Mycobacterium tuberculosis. This is what we expected. In view of continued fever, doxycycline and ofloxacin were added to the treatment. She developed a erythematous malar non-pruritic rash. The repeat musculoskeletal system exam was done and was sent for connective tissue workup, and ANA and anti-dsDNA was negative. A rheumatology consult did not consider SLE in view of negative lab reports. In view of travel history and persistent fever, possibility of rickettsial fever was entertained, and oral doxy was changed to IV doxy as she was not tolerating the oral medication. Despite this, the fever continued and the child was discharged on IV antibiotics with a request to continue. Now, the comment here, now we were having fever, lymphadenopathy, hepatosplenomegaly, and now we have a malar erythematous rash. So that would make us consider the possibility of a connective tissue disorder in the differential diagnosis. A word about anti-ANA and anti-dsDNA. Now, it is always possible that the immune responses occur in three zones, the pro zone and the other two zones. In the pro zone, there will be an excess of the antigen or the antibody, and so sometimes it is possible that despite this being an inflammatory disorder, unless you do this test in frequent low dilutions, there is a possibility of missing the test result here. And a comment about persistent fever, which was considered as rickettsia. As we discussed earlier, the incubation period for a rickettsial disease is maximum 2 weeks from the time of exposure. And this girl has gone to her village a month ago and the fever has been about 12 days. So rickettsial fever, according to the way it behaves in its natural history, is not very high. Number two, IV oral or IV doxycycline, it is said that if it is a rickettsial infection, the response to doxycycline, either oral or IV, is relevant and it is evident within 48 hours of treatment. And here you are given oral doxycycline followed by IV doxycycline. If this child had rickettsial infection, she would have at least shown some partial response. And a word about the use of ofloxacin. The IAP guidelines on rickettsial infection 2017 says that doxycycline is the first drug of choice and azithromycin is the next drug to be added if the response to doxycycline is not very forthcoming. So if the response to doxycycline is not satisfactory, the possibility that this girl had a rickettsial disease is lower on the cards. But we would also like to look at the other non-specific markers of rickettsial fever, like hyponatremia, like hypoalbuminemia, like thrombocytopenia, like leukocytosis, etc., etc. They would give us some corroborative clues to the possibility of rickettsial infection. She was last for follow-up for 2 weeks. She was found that she got admitted to another tertiary care hospital where antibiotics were upgraded to meropenem. A bone marrow aspiration and biopsy was done, which was negative for malignancy. What do I understand by this? Number one, that this child continued with the inflammatory process, and that is why she got admitted to the hospital. Number two, the treating pediatrician has been seeking solace with upgrading the antibiotics, but then there has been no response. So that means upgrading antibiotics is not the answer to this child. We need to look at the differential diagnosis. A bone marrow aspiration and biopsy was negative for malignancy. That is fine, but I don't know what else the bone marrow found. What else can you find in the bone marrow? Number one, bone marrow is a good site for aspiration and culture. We were considering the possibility of brucellosis. We know that brucella grows slowly on the heart-brain medium, and therefore bone marrow could have been a good opportunity for us to draw blood. Even enteric fevers are much more likely to be positive in the bone marrow if you miss it out in the peripheral blood. Well, apart from malignancy, what else they found in the bone marrow is something that we are not aware.
The information by what I got later on after I did this summary was that the bone marrow cultures were negative. Bone marrow is again sent for tuberculosis workup, that was also negative. That's the only two investigations they sent.
So at this point in time, we have probably ruled out malignancy because the lymph node did not reveal anything, nor did the bone marrow reveal anything. High on cards would be a chronic infective process, and next to it would be an inflammatory process, the classical feature of which is not very, very evident to us. It is still possible that some of these features may come up over point in time, but at this point in time, that is what we are finding. Now,
shall we assume, Naghabhushan, that you have ruled out some of the conditions that you had entertained initially? That is, your common infections like typhoid and rickettsia you ruled out.
Yes, yes.
Tuberculosis you have ruled out.
Yes.
Malignancy is definitely not on your cards.
No.
So at this stage, what is your thoughts as far as the initial DD and now what is it changed into?
Now, I would still consider the possibility of brucellosis, which is still possible because she has had a travel. I would still consider the possibility of other zoonotic infections because she has had a history of travel. I would keep on cards the possibility of an acute, subacute inflammatory process like the connective tissue disorders in my mind in view of her age and sex.
Yeah, Dr. Palani says he would like to keep in mind a condition called melibiosis.
That is also possible, like the unusual infections which I discussed earlier, but that again will be diagnosed only by investigation, and there are no other clinical clues to the possibility.
There's a suggestion query whether child lost any weight, significant weight during the hospitalization. The answer is no. Whatever was recorded, there was no significant change in the weight. Any other thoughts?
How was the clinical state after 2 weeks? I mean, what happened to the liver? What happened to the spleen, the lymph nodes, the fever pattern?
No, there was no change in the liver size. No, lymph nodes are the same. The only thing, the jaundice, which is clinically apparent, probably subjectively it was looking little less, but tenderness was definitely there when they requested for discharge against advice.
No, when the child was seen after 2 weeks, was it the same?
We don't have the information because it's another hospital.
Shall I go ahead?
Any other thoughts? Okay, go ahead, Naghabhushan.
Investigations. Let us look at the CBC. The hemoglobin is 10.5. The other things are okay. Look at the neutrophil count. It is grossly low, which is 9.7%. I was just looking at a primary immune deficiency in view of absolute neutropenia called the autoimmune neutropenia due to Na2 deficiency. But this is a chronic autoimmune neutropenia, which means that this girl should have had this recurrent infections even in the past, and therefore based on one value and a girl who was normal until the age of 9 years, that is little unlikely. Platelet counts are slightly low, and let us look at the ESR and CRP. I think I've learned from Dr. Subbarao that when you consider a connective tissue disorder, the ESR and CRP will be sky high, meaning which will be in hundreds. And here you have a girl who has got a CRP and ESR which are not very grossly high. And therefore, considering the inflammatory disorders, including the atypical Kawasaki, and other inflammatory disorders, this ESR and CRP makes them a little less likely. So where are we? We are at mild anemia, and look at the WBC count. This count rules out quite a few things. Number one, it rules out malignancy in addition to the normal bone marrow examination that has happened. Now, it also rules out those acute infections where leukocytosis is very, very likely. A low WBC count can happen in a very few bacterial infections. The commonest among them is typhoid. You have given ceftriaxone, and the clinical features are not like typhoid. Now, in typhoid, you will have eosinopenia and lymphocytosis, but you don't expect a neutrophil count as low as 9.7. So there is something that is happening with the WBC count with a low WBC count despite the fever of quite a few days. Now, bilirubin 2.2 and 1.94 unconjugated hyperbilirubinemia. But look at the albumin. We were looking at the possibility of rickettsial disease where hypoalbuminemia could also be a feature. Now, when does albumin become low? Albumin becomes low in your LFT when the child has got a significant liver involvement of more than 3 weeks. But here we have got a child who has got fever of 12 days duration and the total protein is normal. So is this albumin low a technical error, or if it is low without a technical error, then we would consider the possibility of the child going in for a chronic liver disease or the possibility of a rickettsial fever with a low albumin. And the enzymes are high, but they are not very high to indicate the possibility of a drug-induced liver disease. Because in a drug-induced liver disease, the enzymes are pretty high, and that rules out the possibility. So where are we now? We are looking at the possibility of involvement of the liver by the inflammatory process, which is significant as evidenced by the decrease in total albumin. The blood cultures, no growth. As we discussed earlier, brucella culture takes quite some time, so we have still not ruled out brucella with the blood cultures. What the blood cultures would rule in, if it was done before the taking of an antibiotic, salmonella is one thing that you can pick up easily with a blood culture, so that is a little unlikely. Typhi.im and Vidal are negative, which was expected. Now look at these tests. It is said that all these immunological tests are significant if the derived values are at least 2 times or more as compared to the cutoff values, and none of these are 2 times more. But these values should be considered with a pinch of salt because they would be done at a particular point in time. And we know for sure that the immune response gets better with time. So I would rather repeat these tests after a gap of at least a week or 10 days in order to see if there is a rising titer to the IgM or immune response for these situations, because we are considering the possibility of typhus and brucella quite significantly in our discussion. Now we have discussed about these tests, and probably repeating these tests with dilution is what we would like to do, because she is a girl child, 9-year-old, hepatosplenomegaly, lymphadenopathy, and a skin rash. So the possibility of a connective tissue disorder is also possible. But in a 12-day history child, to have as many as these in a child with collagen vascular disease is a little unusual, because these diseases unfurl themselves over a period of time, and this 12-day time is too short a time for me to consider the classical presentation of a collagen vascular disease. As expected, chest X-ray is normal. What have we ruled out? We have ruled out the possibility of those disorders which will involve the mediastinal lymph nodes. For example, tuberculosis. In a 9-year-old girl, tubercular lymphadenopathy is unusual because that is the presentation of infancy and younger age group. In 9 years, we expect more of fibrocavitary tuberculosis or reactivation tuberculosis. Hodgkin's and non-Hodgkin's can present with lymphadenopathy. They are ruled out. And the other diseases which present with mediastinal lymphadenopathy are ruled out. Lymph node biopsy has not given us.
This is a review of the previous biopsy slide in the different institutions.
So it has not given us any new insight into the possibility of the infections. Now, we have not done a rheumatoid factor test. Toxoplasmosis is generally manifested with eye symptoms and isolated cervical lymph nodes, many times with myocarditis, encephalitis, etc. And toxoplasmosis can occur in a immunocompetent host. What is my take? This child had a cervical lymph. 2 minutes, sir.
Yeah,
the child had a cervical lymph node biopsy, and as I discussed earlier, I would probably do an axillary lymph node biopsy too because the cervical has not picked up anything. But as a clinician, what would I do? A second look at the clinical history and clinical findings, as well as repeating the investigations which were done already. I said they were cross-sectional in nature, can sometimes give us clues because most antibody-based tests show raising titers after a time gap. In short, this child has got an inflammatory process which is persistent and unresponsive to the antibiotics that have been given to the child. I rest my case.
Okay, just before we go, just read some things that has come in the chat box. Palani has said, leukopenia and ANC are very low. That will direct the bone marrow issues. If the ANC continue to persistently low, we have not done any repeat CPCs, only 2 values they have. Hence, that is not valid. And Dr. Ashwini has said, why not stop antibiotic? Yes, in the second admission to other hospital, a trial of stopping of antibiotic for 48 hours was given, and the fever did not change. Dr. Ashwath came late, and we already discussed Kikuchi, but I think his comment is in the context of presence of histiocytes in the biopsy. So what is your comment on the histiocytes on the biopsy? That is for Naghabhushana. And rest of the panelists, if you have got any different thoughts on the after the history, physical examination, progression, and the history. You got 5 minutes before we conclude.
I would like to add that the possibility of Epstein-Barr virus and Kikuchi disease goes low down in the list because both Epstein-Barr virus and Kikuchi, we expect a generalized lymphadenopathy. It is said that in Epstein-Barr virus, the presence of a epitrochlear lymph node is very, very suggestive, and this child does not have it. The same thing is for Kikuchi disease. Kikuchi disease can be very easily picked up on a lymph node biopsy, which this lymph node biopsy has not picked up. The possibility of a Langerhans type histiocytosis is considered lower down in the list because there are no other clues for the presentation of Langerhans type of histiocytosis.
Okay, any other panels on the investigations?
Can I come in now?
Yeah, please, Jagdish.
So I think now if you put this whole thing in summary, we have a child who's had prolonged fever now going on for almost a month. Okay, and we don't have anything to suggest an infective disease, either acute or chronic. None of our tests have shown that. Second important thing is that it doesn't look like a malignancy because your bone marrow is normal, lymph node biopsy is normal. So neither lymphoma nor leukemia is common. The immunological disorders which Dr. Naghabhushana has mentioned, like SLE and RA, are possible still, but very low down. What is more likely, or what is most likely here, is that it seems to be something that is infiltrative into the RES, progressive, which is not a malignancy. So I would put first possibility as sarcoid here. which can present right now, which can present unusually, which can present with fever, prolonged fever, which can present with lymphadenopathy. We do not have a CT scan to show what the lymph nodes in the lung are, but this seems to be more and more looking like an infiltrative disease, unlikely to be malignancy or infection. This is my take.
Dr. Naghabhushana was suggesting lymph node biopsy at a different site. What is the take of the panelists on this comment?
I would do a liver biopsy more than a lymph node biopsy.
Okay. Naghabhushana, would you want to do liver biopsy?
There are two investigations which you have not done, sir. One is liver biopsy and one is a CSF. Now, to do CSF, I have no clues. To do lymph node biopsy, I don't think I would get any more information from the lymph node biopsy because that is an infiltrative process, probably infective. So how much I would get from the liver biopsy, I am not sure.
Dr. Jagdish, you said for sarcoid, you want to do liver biopsy. Why not do CT chest and maybe serum calcium and enzyme levels?
You can do that also. You can do an ACE level. You can do a CT scan of the chest. But here you have direct, see, you need, even if you get a CT scan, you will only show lymph node enlargement. You won't be 100% sure it is sarcoid. So again, you will have to get a biopsy from somewhere to prove that it is sarcoid. The other tests you can do, like for example, acetylcholinesterase and other tests which you can do are not definitive. You can get or you may not get. A biopsy definitely will tell you that.
Okay. The only other addition is generally sarcoid will manifest with mediastinal lymphadenopathy much in addition to other lymph nodes, but here the chest X-ray was normal.
Yeah, I think with that we have unresolved febrile patient. At the end of what is the most common investigation done, some more investigations have been suggested by Jagdish. So I'd like to go back to Naghabhushana to wind up and tell me what he wants to do and what is his differentials.
Now, as I said, this is the statement I would go by. I would like to repeat the investigations which have been done so far. And if I don't get any clues from repeating these investigations, then I would go in for an invasive investigation.
Any specific investigation you have in mind for repeat?
No.
All you want to repeat?
Yes, because there have been, see, as Palini said, I would like to see what has happened to the WBC counts and the platelets in addition to the antibody tests.
Okay, with that repeat tests in mind, does your priority for the differentials change, or what is the order of differentials you think of, you'd expect to get with the repeat investigation?
Now, I would like to see whether that persistent neutropenia is still there, number one. Number two, I would like to see if I can get any clues in the peripheral smear. Number three, I would like to repeat the ultrasound to see whether the spleen now shows something more like a microabscesses. And number four, the IgM and IgG for rickettsia, which we have not completely ruled out whether there is a rising titer. So these are the things that I would like to look for.
Yeah. Any other panelists would like to add on what they would like to do and what is their differentials? Jagdish said it could be sarcoid. He wants to investigate for that. And there is a suggestion of primary HLH, and the investigations we have not done for that. So that we'll keep in mind. Any other thoughts other than this? So I think PET-CT is a suggestion that I think it's mainly for looking for lymph nodes and other masses. So I think that one suggestion. Fine. So can we reveal the final diagnosis, what the treating team decided? Can I share my slide? Okay, I think that's an excellent discussion by Naghabhushana, and there's no match fixing here. So what we did, can we see my slide?
Yes, sir. We can.
Hello?
Yes, sir. Yes, sir.
So what we did was, like Naghabhushana suggested, we did a repeat ultrasound, and that definitely showed multiple abscesses. You can see a lot of hypoechoic areas. And we did a repeat brucella, and that showed a twofold rise, 2.57. And that concluded that this could be a brucella. We went back to the history, and then there was definite confusion that the child, in the 2 weeks stay, 2 months stay in the native, she was regularly consuming unpasteurized milk. And then, but then we had the diagnosis, but we didn't have the answer why the fever is not coming down, despite doxycycline, which is a good drug. So we went through the literature and we added gentamicin for 7 days and continued oral doxy for 3 weeks. She became afebrile after 5 days of gentamicin and continued to remain so. So final diagnosis is a brucellosis. Some of you may ask why gentamicin, and there is enough literature to say that combined use of gentamicin and doxycycline, number one, it reduces the relapse rates, and the frequency with which the remission occurs is also better. There is enough number of evidence to show that. So hence, gentamicin would have been probably the better choice if I had known this information earlier. So with that, we'll conclude of a wonderful discussion of, like Naghabhushana said, usual case with an unusual presentation and not responding to the standard therapy. So I'd like to thank Fever Foundation and all the panelists who participated actively. And I'm sure, like me, Naghabhushana and Jagdish, everybody has enjoyed this session. Thank you very much.
Before we conclude, I won't thank, but I would always share that Dr. Subbarao gave me sleepless nights. And anyway, the sleepless nights made us learn more of clinical medicine. So for that learning, I thank you, sir.
Thank you.
Yes, sir. So there's a question coming in from Dr. SBS, sir. Was PID ruled out?
Was what?
PID ruled out. Dr. SBS sir is asking a question.
No, we didn't. Actually, my stupid brain did not entertain the possibility of PID. One small bit of information I want to give you. I work in 2 hospitals, both related to Manipal. One is a small hospital, Malati Manipal, and the other is the main Manipal, bigger hospital. This patient went discharged against medical advice from Malati Manipal because they thought my treatment was not good. And they came to main Manipal, they got admitted under me again. So the patient's bad luck got stuck with me, which made me stimulate, but my dumb brain did not even think of primary immune deficiency as sarcoidosis. Thank you very much.